very much for having me. I know I have a number of patients and friends who are watching this or will be streaming it afterwards. And so it's really an honor to be able to participate in this and be able to give some information and impart some of our perspectives on the role of targeted therapies and NGS. And the way I sort of label this is what we need to know about targeted therapies and NGS. And I sort of tie them both together because NGS helps us so much determine what targeted therapies we need to use. As all of my colleagues probably have mentioned, we all share patients across the United States, if not further. We've all have weighed in on each other's cases and have all collaborated and helped each other. And it really is truly an honor to work together. It is a great sarcoma community. And so I threw up my email address here. So certainly if someone would like an opinion, I'm happy to see them. I'm happy to sort of help them figure out who best to see in their areas. And I'm sure all my colleagues agree and do the same. And so cancer care has really, as cancer care has progressed, there's really been a trend towards moving to targeted therapies. And by targeted therapies, what I think about is drugs that have fewer side effects and derive benefit for our patients. And so if we look back to really early on, the only thing we're able to do is surgery. And as times moved on, there was the development of radiation therapy, the development of chemotherapy, and then certainly in the era that most of us have practiced in the last 20 plus years, we really started looking at more targeted therapies and then more recently immunotherapies. We're really looking to modify pathways, processes that block cancer. And so what I'm always thinking about is cancer does one thing, and all my patients know I say this all the time, the only thing cancer knows how to do is grow. And so what we're really trying to do is block the growth of the disease, but we're also trying to kill it. We're trying to prevent it from getting worse and really modify how we view this. And sort of that sarcoma becomes a chronic condition as opposed to an acute condition. An acute condition is something that will impact life almost immediately, whereas chronic condition is something that you live with. And we really want to get it to that point. And so targeted cancer therapies are drugs that are designed to interfere with specific molecules necessary for tumor growth and progression. So ideally, a primary goal of a targeted therapy is to fight the cancer cells with more precision. And so if you're more precise, you're potentially able to have fewer side effects, and you're also able to have more predictable side effects. When we target cancer therapies, we think about two major classes. We think about antibodies and small molecules. The way I sort of think about it is that the antibodies, which traditionally are IV therapies, will target the cancer cell from the outside of the cell, whereas small molecules penetrate the cell membrane, interact inside the cell, and these are traditionally oral drugs. And so these would be pills that you pick up at a pharmacy. And so if you look at an entire list of FDA-approved drugs that are on the market, and this list is a few years old, and so obviously this has gone beyond, but essentially everything in blue are drugs that we do not utilize very often for our sarcoma patients. And then I started to highlight a few of them that have come about. So we have avapritinib, which is approved for GI stromal tumors. We have denosumab or Xgeva that we often use for our giant cell tumors of bone. We have imatinib, which was the first drug that we started using for GI stromal tumors, but we also use it for dermatofibrosarcoma protuberans. And there are other indications for it. But we also see a list of other drugs, and these are drugs that we're not often touching, not utilizing for our patients, or these drugs are not approved for our patients. And therefore, the question really becomes is how do we incorporate some of these other drugs? They're all FDA approved. So how do we find a path for which these drugs also will have an impact for our sarcoma patients? We have over here the pazopanib, which is approved for soft tissue sarcomas, excluding liposarcomas, as well as for renal cell. We have pexidartinib, which is a CSF1R inhibitor, and it's approved for tenosynovial giant cell tumors. And then we have regorafenib, approved for colorectal cancer, for gastrointestinal stromal tumors as well. And then ripretinib is a new drug to market from a company, Decifera, which is approved for GIST. We have sunitinib, which is approved for renal cell, GIST, and pancreatic neuroendocrine tumors. And then tazemetostat, which is an EZH2 inhibitor for epithelioid sarcomas. And so we have made a lot of progress. If I go back on the list and I think about the first time I started using these, avapritinib wasn't on the market. Pexidartinib wasn't on the market, ripretinib wasn't on the market, and tazemetostat wasn't on the market. And so those are four drugs that have come about in the last few years. And so we are making strides. We are increasing our portfolio. for our patients, but we still have all these other drugs that are approved that we're not having access to on a regular basis. So how did pazopanib get approved for sarcomas? So pazopanib is a small molecule tyrosine kinase inhibitor, and therefore it is a pill. It is an inhibitor of growth factor receptors associated with angiogenesis or blood vessel formation around tumors, and therefore will impact the nutrition that is given to these tumors to grow, and therefore you're really hoping to affect tumor cell proliferation. And the pazopanib does inhibit several factors. It's not just one thing. And so it really does have a lot of areas that it targets. Some of these targets drive the cancer, and some of these targets are probably passengers to the cancer and therefore don't impact what happens to your cancer. And so we're always looking to attack the driver of the cancer. So how did the study get done? So the study got done because you had 246 patients and 123 for a total of 359 patients that were willing to go into a clinical trial that utilized placebo. And so what this meant is that 2 out of every 3 patients got active drug pazopanib, but 1 out of every 3 accepted the fact that they were going to get a placebo, which was not an active drug, in order to really evaluate if this drug would be beneficial for everybody. And so it really does make a huge impact and really does show the entire sarcoma community how we have to do some of these clinical trials. We do less and less placebo trials nowadays, but these were always very important. And I have a number of placebo studies that I'm going to show you. And so in this study, we had the primary endpoint was going to be progression-free survival. So how long did you live without your tumor growing? And then we also looked at how long people lived in total. We looked at how the tumors responded. We also looked at people's quality of life, which is very important. And so what we saw is that pazopanib, patients on pazopanib had a median time until their tumor grew of about 4.5 months. And if you were on placebo, your tumor grew after 1.6 months. And so this really was a meaningful difference. And there are 2 lines on a curve. You see the top line is the line that always does better, and that is in red. The bottom line is in blue. So the red line is the ones that are getting pazopanib. The bottom line is getting placebo. And so we clearly see an improvement. And we also saw that pazopanib worked right across the board. It didn't matter what type of sarcoma you had. So if you had leiomyosarcoma on the left side, if you had synovial sarcoma in the middle, or if you had other soft tissue sarcomas, you derived a benefit from this drug. And the benefit was very similar in all 3 groups. And so pazopanib demonstrated a progression-free survival benefit irrespective of what group you were in. And I have to just emphasize this study didn't include patients with liposarcoma. So we have that phase 3 study. That's the one on the left. It is the one from 2012. And that gave us our first approval of pazopanib for soft tissue sarcomas. Over the next 5 years, we tried looking at other drugs to bring to this landscape. And the ones that are circled in red are the studies that actually came to the FDA and led to a drug approval. Unfortunately, the other studies, which are all in blue, did not get FDA approval, but it really highlighted that there is this community of oncologists that are driven to improve where we stand with respect to cancer care for sarcoma patients. And even if it does represent 1% of all cancer patients, you have a group of dedicated researchers around the globe that this is their #1 priority. So what have we learned in the last few years? Well, we learned that there's a condition called Tenosynovial giant cell tumor or pigmented villonodular synovitis. And this is a condition that is driven by translocations involving the CSF1 gene. And so as you have increased expression of the CSF1 gene, you end up causing this condition, which is really a proliferative inflammatory effect in the synovium. Very rare, but if you're that patient who has this condition, you want a drug for it. We know that if it is localized, you could have a surgical resection. Sometimes you need radiation. So there are a lot of options for our patients. But if you have disease that is spread or disease that is non-operable or disease that is recurrent and you can't have more radiation, you really for many years were left struggling to figure out what the best approach for this would be. And so because there is an overexpression of CSF1R, let's target it. And so there was a study that was designed again versus placebo because there was no standard of care. And so you have nothing to compare it to. And so what they did is they randomized patients in a one-to-one fashion. Patients had symptomatic or advanced tenosynovial giant cell tumors. Surgical resection was felt to potentially worsen their function, or it would lead to severe morbidity, and it just wasn't a good idea for these patients. And therefore, patients were randomized to receive pexidartinib, which is the drug that would attack the CSF1R, versus placebo. So what happened to these patients? The graphs on the left are the ones for the patients who got pexidartinib. The graphs on the right are for the ones who got placebo. So on the left, what we see is that every line represents an individual patient. And what we see is all the lines are going down. So what we have is 0 is the mark at which everyone starts. And at 0, that's the volume of cancer or volume of disease that someone has. As the lines go down, that means the volume of disease gets less. As the lines go up, the volume of disease gets higher. And so what we see is almost every single patient who got pexidartinib had improvement of their disease, which really was profound and really does make a difference. We see in number F, which is at the bottom right-hand side, that patients in there were the crossover group. So those originally got placebo, but then they got pexidartinib, and we saw there too, everybody derived a benefit from the drug. So what we know is that based on this, the FDA did give approval of pexidartinib for patients with tenosynovial giant cell tumor. The approval was based on a durable overall response rate. No patients who received placebo had a response. After 25 weeks of treatment, the overall response rate was 38%, and 15% had a complete response to therapy, and 23% had a partial response. So not quite 100% shrinkage of the tumor. 22 of 23 patients who responded had been followed for a minimum of 6 months and maintained the response for more than 6 months. So this was really an impactful, profound difference for our patients. Moving along to other rare conditions, we have epithelioid sarcomas. And we had a very large clinical trial looking at several cohorts. And this was a phase 2 international multi-center study using a drug called tazemetostat in adult patients with INI1 negative tumors or relapsed and refractory synovial sarcoma. The 5th cohort, and so each cohort had a different disease. The 5th cohort was specifically patients with INI1 negative epithelioid sarcoma. The INI1 negative is a reflection of a pathology evaluation of the epithelioid sarcoma. So when the diagnosis comes that a patient has an epithelioid sarcoma, then the pathologist could do a test to see whether or not the patient is INI1 intact or negative. So this was a 2-stage design. Enrollment in cohort number 5 initiated in December of 2015 and closed 3 years later in September of 2018. The last information came at that point. It was conducted at 32 sites across the United States, Europe, and Asia, and it was sponsored by Epizyme. And what we see moving all the way to the right-hand side of this slide is that of the patients, when we look at the 62 patients, the overall response rate was 9 or 15%. But if we go down a few columns, you go down to the one that says 35, and that's stable disease. And so what we know is that 56% of patients' tumors stabilized. So stabilized in our world means either a little bit smaller or a little bit bigger, but nothing too dramatic. And so what you really do have is that you have 50, 60, 71% of patients derived what we would consider as an improvement or stabilization of their disease, which is very impactful. If we break it down even further, again, using these waterfall plots, looking at the curve, 0 is the baseline of where everyone starts. If the bar goes up, that means the tumor grows. If the bar goes down, that means the tumor shrinks. And what we saw is that 51% of patients demonstrated a reduction in their cancer lesions that are being measured. So this was the first prospective study conducted for a rare sarcoma called epithelioid sarcomas. The treatment with tazemetostat, which was investigational at the time, was the first in class. It's an oral EZH2 inhibitor. And what you have is a response rate of 15%, decrease in tumor size in 51% of patients, and it was durable. After about 60 weeks, the median duration of response was not reached, meaning we don't know how long someone could stay on this drug for, which is profound. A median progression-free survival of 23.7 weeks was established, and 21.3% of patients were progression-free at 1 year. And the median overall survival for these patients was 82.4 weeks. And so we also know that tazemetostat is generally well tolerated. There were no treatment-related deaths and less than 2% definitive discontinuations. And so when we do drug development, looking at drugs in any landscape in oncology, really having a 2% or less than 2% definitive discontinuation rate is almost unheard of. So tazemetostat was approved in January of 2020 for an accelerated approval for the treatment of patients with metastatic or locally advanced epithelioid sarcomas not eligible for curative surgery, and a landmark phase 3 study to confirm these results is currently underway. So I hope I'm able to show you today that sarcoma is a targetable disease. And I think we highlighted that by using the examples that we use of the epithelioid sarcoma, looking at the Tenosynovial giant cell tumors, but we also use targeted therapies when we look at giant cell tumors of bone, when we look at inflammatory myofibroblastic tumors, when we look at our desmoids, our alveolar soft part sarcomas, our Ewings, our chordomas, our clear cell sarcomas. So really it is hitting a lot of patients, our liposarcomas, our angiosarcomas. So the question is, how do we find the right targets? Well, all of us on the call that are presenting today are very fortunate because we all work with incredible teams, and I'm no different. It takes a village to make a difference. So I work with this incredible team at City of Hope, and it's a team that is comprised of people that are off this list as well, unfortunately, the researchers that are in the lab, but also we're working with our surgeons, our orthopedic oncologists, our surgical oncologists, our thoracic surgeons. We're working with the urologists. We need a very strong pathologist. You need other medical oncologists around you. You need radiation oncologists. And as a team, we discuss the cases together. And as a team, we could bring consensus and we could push things beyond where we know that they need to be. And we just share ideas and help drive the system. And so when we look at future directions, a lot of the future directions have to do with NGS. And so as cancer care has progressed, there has been a trend towards targeted treatment, but the potential benefits of targeted therapy is only realized if the patients can be tested and matched to the appropriate treatment. There are many genomic alterations that are rare. And if you only test for one alteration, it's not feasible, but you're going to end up missing the other ones. And so there are various methodologies that are currently available, but one of them, looking really at NGS as the platform, it is comprehensive, it is a diagnostic test, and I won't say any company in particular, but there are several companies as well as in-house platforms that are able to do it. So at City of Hope, we're very fortunate, as my other colleagues are as well, that you're able to do a lot of these in-house at your hospital and that you don't have to delay finding these answers by sending them to other companies. So there is certainly a growing role for precision medicine across all of oncology. We know with advances in medicine and genetics, over 135 drugs have been developed since 2018 that included genetic information in their label. And a 2015 survey showed that over 40% of drugs in development include biomarkers in their research and development study design. So there's an estimated 69% increase in the number of therapies developed by the year 2020 and beyond. And really cancer remains as the vanguard of precision medicine. So what do I mean by precision medicine? Precision medicine is really trying to change the way we approach patients versus conventional medicine. And so if you have conventional medicine and we think about radiation, chemotherapy, surgery, oftentimes all patients with the same disease are treated the same. So if we were to offer a patient adriamycin, which we do every day of every clinic, it's an incredible drug. We're offering you doses based on your height and weight, and so that is somewhat precise. However, the drug is the same based on the characteristics of the tumor under a microscope, as well as your characteristics, but it's not really looking at the genetics of the tumor. When we look at precision medicine, we're looking at targeted therapies, immunotherapies. We're looking at finding a drug for you that is because of you and your tumor and not so much because you have a leiomyosarcoma or a liposarcoma. It's specifically about the genetics of your specific sarcoma. And so one drug could be effective for 3 people, one drug could be effective for 1 million people, but one drug may just be effective for 1,000 people. And we need to find these drugs and these patients as well. And so the aim of precision medicine is to prevent, diagnose, treat disease based on specific biological, genetics, environmental, and disease characteristics. In cancer, we're using therapies that may benefit a subset of patients with a tumor that have a specific genetic alteration or protein expression pattern. And so we therefore need to do a genomic profile of our patients for the right case. Do I do NGS and genetic testing on every patient? Absolutely not. Do I do it for a subset of patients? In my practice, I predominantly do it for patients with metastatic disease or disease that cannot be taken to surgery, and therefore trying to get more information about their tumor. I should also say it's the genetics of the tumor, not the genetics of the body. So we're not talking today about what genes are passed down from our parents. And so really what we're looking to do is use this tool. So you have the patient with their disease, you have this biomarker profiling, these diagnostic tests. And what you're really looking to do is whether or not you could use these as screening, prognostic markers, predictive, monitor patients. So really take them into a context and make it a little bit bigger than what we currently use it. We use them often to find therapies that we use as more, it will predict whether or not you respond to therapies, but it'd be great if we could use them earlier on, and it'd be great if we could use them to monitor therapies as well. So really to realize the potential benefits of precision oncology for a specific cancer, actionable alterations must be matched with appropriate therapies. And the only way to find an actionable alteration is to look for it. And so really we're trying to find essentially an FDA approved or investigational drug that is targeting a pathway that we find in your tumor. And so your tumor will have a genetic alteration or produce a protein product that we then could target. And so we're really trying to hone in and give you a very strict treatment. And so we have been doing targeted therapies for some time. The earliest one is trastuzumab or Herceptin for breast cancer in the 90s. We have imatinib for CML. We started developing drugs for specific type of lung cancers in the early 2000s. And then as we started moving through 2010 and beyond, we started looking at more targeted therapies, really finding rare mutations. But we started in 2017 finding drugs that are approved based on an alteration that is irrespective of the cancer. And therefore, we're starting to treat the genetic abnormality and not so much the cancer. It doesn't matter if you have breast cancer, lung cancer, or sarcoma. If you carry this genetic abnormality, then you're all treated the same. And really, the potential benefits of targeted therapy is only realized if patients could be matched to the treatments that we're looking for. And so therefore, clinicians must make informed decisions about who to test, what to test, which assays to use. We are all very well versed in the different companies that exist and the reasons for choosing the assays that we choose. And therefore, you just need to make sure that when you're going through this process, you're doing it very thoughtfully. So we're looking essentially for mutations, which are changes in the DNA sequences. We're looking for variations or rearrangements, which is changes in orientation, location, or numbers. And we're also looking for copy number variations. So really looking for what we call gene amplification. And so we know that most actionable alterations are uncommon, and therefore we can't look for individual ones. We use these NGS platforms that really look for thousands and thousands of exons on hundreds of genes in order to find the one or two alterations that each patient may have. And so the easiest way to detect—
remaining, please. 2 minutes.
Okay, the easiest way to detect these genomic alterations is by NGS. And I'll just use an example. So we looked in our sarcoma program at a number of patients that we did NGS on in sarcoma. We looked at 117 patients that were done in a 2-year period. And what we did find is that there are a number of actionable mutations amongst patients, and we really did impact differences. We treated patients with Ewing sarcomas with drugs that are approved for lymphoma. We treated patients with leiomyosarcomas with lung cancer drugs. We used immunotherapy for a number of them. We treated patients with other drugs that are approved for AML, drugs that are approved for melanoma. And so really, it really is to do a personalized treatment for our patients. And so the concluding slide is that 34% of patients have a potential actionable mutation. Treatment of 8% of patients was altered by our NGS results in our study. Incidence of actionable mutation increased over time, and partial responses in select refractory patients were observed. And so the question is, what does all this mean to you as the patient? I think what it really means is that you need to get a team behind you. You have to get a team behind you that is really working with you, knows the latest data, working with your physicians, working to really get you to the point of where you need to be so that your outcomes are the best outcomes that you could possibly have. I think as an informed patient, you go on to websites, you look for clinical trials. I threw up our clinical trial here, but you could also use clinicaltrials.gov. You could also use any of the advocacy groups to help you. And that is my last slide.
Thank you so much, Dr. Agulnik. And we do have time to take a couple of questions as well. So I know we've got some in the Q&A.
Okay, so let's see. What do you think? Well, okay, what do you think of genetic tumor analysis for testing drugs to determine more effective for that specific patient? Engine Certis mouse studies. So
I think, so if I'm getting the question right, I think we're looking at some of these experimental opportunities that patients have where they could utilize companies to see whether or not they could implant their tumor into mouse models and develop drugs that way. Is that your understanding, Gina, as well?
yeah, so
okay. So I think these are experimental. My understanding is they're very costly. I haven't seen enough data to say that this will materialize. I don't recommend it necessarily for my patients. My recommendation for my patients has traditionally been FDA approved companies with platforms that are FDA approved. And I think we do derive a lot of information from that.
Okay, and the success rate using Ibrance for well-differentiated retroperitoneal liposarcoma.
Yeah, so I think that's a great example of targeted therapies. I think there are several drugs, including Ibrance, that have been extensively studied. We've all been at meetings and seen the data together. There is a subset of patients that will derive a benefit. The benefit that they derive is not going to be, in my experience, and the data would suggest this, it's not going to be shrinking so much of the tumor, but it's going to be stabilizing the tumors in someone that potentially cannot go to surgery. And so it can be effective for patients, and the duration of the effectiveness varies between patients. Obviously, these are all individual patient cases, but it certainly is worthwhile to attempt and see whether or not you could get somewhere with it.
Okay, I have metastatic liposarcoma. Genetic sequencing showed no actionable mutation. Did show P53 mutation. Temptis did this NGS. Is targeted therapy out of the question?
So targeted therapy is not out of the question. And so the question is going to become, at what point do you have something that you may want to look at again? So the average patient, so the number one thing that we do see is TP53, and that is certainly in our sarcoma patients. And there isn't anything that we utilize as actionable for that at this point. The only targeted therapy that is approved across the board would not be approved for liposarcoma. And so in the short term, would I use targeted therapy that is FDA approved? No. Would I consider something on a phase 1 clinical trial? Certainly. Would I look to see whether or not we have a tumor mutational burden number that could drive us towards using immunotherapy? I certainly would like to see a number above 8 to 10, and that could possibly be something that you would utilize.
And then also, these tumor specimens, the data is saved. So yes, right now we don't have anything for P53, but there may be something in the future. And
correct.
Also, if we do see the majority of, there are a lot of tumors that have P53 mutation, and that's probably just a mutation on the tumor. But if it is shown up, then we do recommend that you go to the genetic counselor, because they can do further testing to see if that mutation was passed on from your parents and you have another condition called Li-Fraumeni syndrome. So a lot of times when we send the tumor specimen out for NGS, which stands for next generation sequencing or molecular profiling, or I'll use interchangeably. Remember, we have to have many terms to confuse you guys. We have to keep us in business, So, oftentimes when we do send these out, we may not have any actionable, but they can still be helpful down the line. So how can I know if targeted therapy is the right treatment for me?
Yeah,
Very
so I
broad
think,
question.
I think the question, having a discussion with your medical oncologist is the greatest way to know if targeted therapy is the right therapy for you. I don't think the onus relies solely on the patients. I think that the patients have to be well versed to understand certain terminology. I think that the things that you want to do as a patient is make sure that the pathologist that is looking at your biopsy specimen or your tumor is well versed in sarcoma. And that's a very easy question to ask someone. Where was my pathology reviewed? So if you're going to a small hospital that sees 2 sarcomas a year, you probably want to have that reviewed at a high volume center, or you definitely want to have it reviewed at a high volume center. And it may have already been done. So a lot of the sarcoma specimens are sent around the country in order to get the reviews that are necessary. And so the first thing you want to do is, then the second question is the therapy right for you? Well, based on the history, I'll say that there is something approved, yes or no. And then the next question is to ask, should I be having an NGS profile done on my tumor specimen? And if the answer to that is yes, you need to make sure that you follow up with your doctor, I think, to see. It takes probably sometimes 4 to 8 weeks, and see whether or not that report is back. And then I think it's important to sit down with your doctor and go through the report. Don't just have them say there's nothing. Make sure you look at the report, because the report is important for everyone to make sure that we all understand what it shows. And I think it is an important conversation. The same way you sit down with your pathology report with your surgeon, I think you sit down with your NGS report with your medical oncologist.
We got time for one more.
Okay, can you talk about the phase? Oh, I think we lost Dr. I think what we'll do is we'll have Dr. Agulnik answer that question about the phase 2 trial. He'll type it in because I think he just lost a little bit of the cell service.
Yeah, I noticed the last couple of seconds his bandwidth was getting a little.
Yeah, he
so,
was on the frozen side. He was frozen.
So we can move on to Dr. Forster, I guess now. Should we answer it
and then
afterwards, right?
Oh, he's back.
Sorry,
Okay.
I got kicked off for a second. I apologize.
And so maybe if you could, there were some questions specifically for you. If you could just type those in.
Okay, perfect.
That would be great. A couple of questions about trials that you had at City of Hope and everything. Thanks so much.
Good to see everyone. Thank you.
Thank you so much for joining us, Dr. Agulnik, and for your support as well.